Now we shift over to another session, a very important session now, and this will be more on diabetes and endocrine, other organs of endocrine, and also a little bit of COVID. For this first session, we have another very wonderful speaker, Dr. Abdul Hamid Zargar. I don't think anybody requires to know much more about him. He is one of the best speakers we have heard in diabetes, and practically no conference is without his deliberation. For this session, I have the chairperson as Dr. Anil Kumar Agarwal, and we have a moderator, Dr. A.S. Devda. I request Dr. Anil Agarwal to carry on with the session, please. Dr. Anil Agarwal.
I am proud and privileged to introduce Dr. Abdul Hamid Zargar, who is a renowned endocrinologist of India. He is more than 150 research publications, national, international journals, received numerous awards and delivered numerous orations, editor, associated editor and reviewer of many medical journals, chairman, independent ethics committee, Escorts Fortis Hospital and Research Center, New Delhi, past president of Endocrine Society of India. Now he will deliver a lecture on glucose lowering treatment during pandemic, before and after SARS-CoV-2 infections. Now I invite Dr. Abdul Zargar for his deliberation. Thank you, sir.
We are not able to hear you, sir.
Are my slides visible?
Yes.
Yes, they are.
Good morning, dear friends, and thank you, Dr. Manawat and his colleagues, for asking me to give this talk this morning. In the next 15-20 minutes, I'll be talking about fundamentally a very major issue, and this is a contemporary topic, that how do we handle dysglycemia during this COVID pandemic? Because we have known in the last year and a half, one of the worst hit segments from the point of view of hospitalization, intensive care management, mortality, post-COVID morbidity, diabetics have been hit the hardest. So very relevant topic for the day. If we just look at this slide, this in brief tells you why should we be talking about COVID-19, SARS-CoV-2, and diabetes. Whenever a person gets infected with this virus, all of us know that a big chunk of people may either have an asymptomatic disease or might have mild to moderate symptoms, which may not be doing a lot of damage to the body. But in 10 to 15% of the patients, the disease may not be that innocuous. And particularly, not that innocuous to the lungs, kidneys, and the beta cells. We know that whenever there is an inflammatory state, whenever there is an infective state, it puts a pressure on the glucose metabolism, particularly in people who already have some form of a dysglycemia or have diabetes as such. Sorry. Are the slides visible?
Slide is visible, but not moving.
Yeah.
All right.
So just click on the slide, sir. Click on the slide and it'll move.
Now you see, when we look at SARS, two important things happen. They have been shown to infect and damage beta cells, like islets, as happens in type 1 diabetes mellitus, an infective process that has the potential of damaging beta cells. And particularly if you look at diabetes, type 1 diabetes, you already have sufficient number of beta cells that have been destroyed. And type 1 almost knocked out from the beginning. Now, whatever little bit of beta cells are left in patients with type 2 diabetes mellitus, if this islets occurs, then understandably, whatever little bit of insulin was coming from the endogenous sources would not come. All of us know that this is a disease that is associated with what we call so-called quote-unquote cytokine starve. And that in itself puts a pressure on the whole excess of insulin, glucose, and the receptor. Now, different things that we see today and that we have seen particularly in the last year and a half. A person, when he is admitted with a significant COVID symptoms, may have hyperglycemia at admission, may have a worsening of the metabolic control during that phase, who was very well controlled diabetes, or for the first time may develop new diabetes. And I've seen hordes of it all along. The circumstances under which all these things will happen if a person is obese. And I must tell you, apart from diabetes, which has been shown to be associated with an increased morbidity and mortality, obesity, even in young people, has been associated with increased mortality and morbidity. And if there is an associated coagulopathy, which is so rampant in 10 to 15% of people who have significant COVID disease, and these circumstances are the potential of putting a person into diabetic ketoacidosis or hyperosmolar coma, HONC. And if this person already had a cardiovascular comorbidity, a renal comorbidity, it is understandable the situation would not be in the favor of the patient. Now, this is some of the first data that came in from China, the initial ones, and later from other places. If you look at this graph, you can see it. Look at the top. When you compare diabetics with non-diabetics, mortality was almost 3 times more in diabetics than in non-diabetics. In fact, one of the first papers that was published in Feb 2020 only from Wuhan, the mortality in non-diabetics was documented to be 2.5, whereas in diabetics it was found to be 7.3. And you can see all along in this thing, even mortality 5 times more in diabetics than in non-diabetics. As I was just now telling you, apart from diabetes, obesity is another thing which has been hit hard. And if you look at our own country, forget about the global scenario, United States, where obesity is so rampant, mortality has been so huge. In Latin America, where obesity is so rampant, mortality has been huge. Even in India, if you look at Bombay, if you look at Bangalore, metropolitan state, which are relatively obese than rural India, morbidity and mortality has been much higher. This is some data that we have been part of, published a few years back in Lancet. We showed that if you look at Indian men in 1975, Indian men were at the position number 19 in terms of obesity globally. Today we are at number 5, and this predominantly is urban and semi-urban areas. And if you look at Indian women, who were again in 1975 in terms of obesity at position number 19, today are at position number 3. So that's why, these highly dense, obese metropolitan cities have not been doing that well. And this obesity is worsening 10 times worse now in the younger people also, moving slowly to the rural areas also. One important thing that has come to the fore, that when a person gets infected with COVID-19, what determines his prognosis is how good his pre-infection glycemic control was. If a person does not have a comorbidity, if a person's hemoglobin A1C is less than 7, his mortality, morbidity would be at par with a non-diabetic person. And if you just look at this data, it's so amazing. Just look at, as you grow, at the top cartoon, if you go from a hemoglobin A1C of 6, 8, 10, as the hemoglobin A1C goes up, mortality goes up. And on the left side, lower graph you look at, if you look at a hemoglobin A1C of 6 to 7, in fact, it is protective. It means the person has all along been taking care of himself. If hemoglobin A1C is 7.1 to 8, mortality has shifted to the right side. And if it is more than 10, it has almost doubled up. And the same data is defected if you take mortality of 1 at a HbA1c of 8. As the A1C comes down, the percentage of mortality goes down. And in many studies, it has been calculated that if hemoglobin A1C is reduced by 1%, risk of developing severe COVID-19 reduced by 21%. This is some data that has been published from India recently, again showing that why diabetes is worsening. During this period of lockdown, all of us know, we have our own personal experiences, patient experiences, that life has become quite sedentary for everybody. Snacking has become common. Total consumption of calories has increased by 1/4, while as time spent on exercise, and exercise does not necessarily mean a structured exercise morning, evening, even walking around day-to-day course, going to the market, going to the shop, going to the work, the total consumption of calories by that is decreased by almost half. So this again tells us that why we need to be careful in our own patient population, why prognosis is worsening. If our COVID things were better, but these things are liable to put it off the rocker. So we need to keep a proper visual that our diabetes insipidus remains controlled. Why? Because epidemic is not yet over. We are still there. So we still need to be at it, keep our patients optimally treated so that if at all there is a problem, they are spared the complications, they are spared the mortality complications. This is some data that we published from SCIMS about 2 decades back. This was the 10 years mortality data, probably the only mortality data published from India. When we postulated that the commonest cause of mortality in diabetics in this part of the world is infection, many people did not believe me, but then there was a paper published from PGI, which exactly said, where said about 1/3 of people with diabetes do succumb to infections in this part of the world. The paper published from PGI endocrinology department said, no, it's not only 1/3, it's more than 40%. So infections have been a problem in diabetics all along. This is the follow-up 10 years mortality data that we again published a decade later. That was in 2009. We found out that diabetics now live longer, because now by that time ACE inhibitors had come in. We were statinizing people, more intense treatment was given. So gap between a diabetic and non-diabetic was shrinking, but infections continue to be #1 killers. So we need to be careful all along. Now, hyperglycemia during COVID infection, how do we manage it? Now that it happens, how do we manage it? All of us know that whatever treatment modality you look at metformin, you look at glitazones, you look at sulfonylureas. If glycemia has been well controlled, and if the disease is mild to moderate, we do not need to unnecessarily fiddle with it. It's only that if disease worsens, dysglycemia worsens, a person is hospitalized, a person needs oxygen, a person needs intensive care, a person needs steroid therapy for a long time, then we need to intervene. In a similar fashion, all those drugs, the gliptins we have been using, SGLT2s we have been using, GLP-1 receptor agonists we have been using, we do not need to get into panic in almost 85 to 90% of our own patients, even when they have COVID. They will continue doing well, and we continue making all those small little alterations in their treatment that we would otherwise do during our own follow-ups or during non-COVID infective processes that we routinely do. Insulin has an important role. People who are on insulin, their insulin requirement might go down, particularly the ones who are sicker. The insulin regimens might need to be changed. There might need to be more aggressive insulin regimens, at least during the active phase. This in general shows, if you look at the impact of different drugs, different regimens, understandably, insulin would do the best because it can bring down hemoglobin A1C to any level. In this country, we have a huge experience with premix insulins, and we usually start that insulinization not at 7.58, 9, 10, and usually can get it down to up to -1.9, almost 2% of HbA1c reduction. In the current times, out of those 15% people, 5% people who get sicker might need a more aggressive therapy, a basal bolus therapy. Many of us have been comfortable with the premix all our lives. And recent newer drug formulations like Rhizodex has been like a premix, but the data has shown in many patients it will behave like a basal bolus. So we have many of these alterations in people who are sicker. Metformin has been shown to have some beneficial effects. In fact, some data published recently show that people who have been on metformin, their interleukin levels have been lower than in non-metformin diabetic patients. So thereby meaning probably the magnitude of cytokine starve has not been that bad. So the need for hospitalization would be lesser. Need for oxygen would be lesser. Need for getting into an ICU would be lesser. This is one slide that I would like all my colleagues to focus on. This is the famous recovery collaborative group study, which was published in NHM. After this, steroids came to the work. Look at the top level, the very top of this. This person is on intensive invasive mechanical ventilation. And if you give him steroids and other supportive treatment, mortality would be reduced by 40%. Because in them, otherwise, mortality would be huge. And 40% is a huge. Only in people who are on oxygen therapy and get sicker, but do not need an invasive or mechanical ventilation. If given steroids, mortality would go down by about 20%. But if you're routine patients, run-of-the-mill diabetics, you start giving steroid therapy. I've seen in the last 7-8 months in particular, ever since the steroids became popular in patients with COVID-19, people randomly describing at home, people take prednisolone 60 milligrams, take dexamethasone, a tablet or injection 1 bit, methylprednisolone so much. Mortality has been shown to worsen with such a behavior. Because then, the moment you start doing it, you are not looking at the contraindications of this. You're not looking at the prognosis of a person who has a stable COVID and is likely to make a event-free recovery. So we don't need to be random about it. So patients need to be selected properly in consultation with the guys who have some experience of treating people. Now, this is something that I would love to look at. You can have patients who have, for the first time, diabetes when you're looking at them. As I was just telling, they walk into the hospital, they're sick. You find out their fasting blood sugar is less than 140, or pre-meal is 140, 180 random. Not many blood sugars crossing 200, 250. You can watch them. You can give them, a diet accordingly. But if their blood sugars start moving up, and particularly if fasting is around 200, 250, we can do conventional therapies, routine therapies. But if blood sugars go out of 300, 400, and patient needs hospitalization, then the safest thing to do is give basal bolus therapy. Because now, when a person is sick, you never know when he'll be sick enough, and the intake of calories might become unpredictable. So basal bolus therapy would be the best. And in fact, if at any stage blood sugars go very high, 400, 500, and you have a doubt of diabetic ketoacidosis, then IV infusion should be started. If a person is on oral anti-diabetic drugs at admission, if blood sugars are reasonably okay, not many sugars going beyond 200, maintain it. Just watch it. If blood sugars go a bit uppish, fasting 150, 160, postprandial 200, 250, up titrate whatever oral hypoglycemics you're giving them. But if they start getting beyond 250 at any stage, start small amount of basal insulinization. And if again you start getting a pre-meal blood sugar of 300, post-meal 400, then the time has come. Either if the person is conscious for basal bolus therapy, and if you have a doubt of unpredictability or doubt of a possibility of a diabetic ketoacidosis or hyperosmolar state, start a diabetic ketoacidosis protocol. And if people are already on basal bolus, then the same thing needs to be continued and maybe need to be fortified, few units up and down titrated. But during all this period, again, I must tell you, we have seen many people who have been on basal insulin alone who needed up titration. I've seen many people, giving ultra short acting insulin in the morning before breakfast, before lunch, and giving a co-formulation like Razodec before dinner, where you will have an S-part also, you will have a long-acting Tresiba also, Diglodac, and then shifting over the same 2 doses till you are out of woods. Position again becomes tricky if there's a person in whom you are not giving anything orally. Then you have to continuously monitor that person's blood sugars and find out what best can be done by IV infusions. Now, what do we do after that? Once the whole show is over, patient is recovering. I must tell you, in many patients, there will be a very prolonged post-COVID phase. And this post-COVID phase is likely to be proportionately more in patients with diabetes. I've seen so many people, whose lung dysfunction continues. I've heard of people whose renal dysfunction worsened, people who developed lung fibrosis, who already had a compromised cardiovascular system, renal system. So they might need on a prolonged basis fibrolytic agents and steroids. So we need to be on guard according to the diabetes. And there are many apprehensions in giving multiple doses of insulin. People get fatigued after quite a few months having that 5-6 doses of insulin. And in the current regimens, probably, one of the best things that I have found in the last 1 year, I'm so happy we have these newer drugs available, because we know these drugs are costly. But if in a big chunk of people, you can give some comfort and just give them for 3 to 6 months, and then by the time, if they make it well, they go back to their own oral regimens, giving a dose of Idegasp or 2 of them. Many people have tried an oral hypoglycemic in the morning and Idegasp in the evening, and results have been phenomenal. And in fact, one of my colleagues, Dr. Bhattacharya, this is a paper that was a poster presentation in this year's ADA, where he said that 1 dose of Diglodac and Aspat before dinner and giving Empa and Lena in the morning. In those people who had COVID, had received dexamethasone and continued with them, and in his study, they seem to have done pretty well. So the bottom line is, carefully adjust therapy regularly, ensure adequate metabolic control even when a diabetic does not have COVID. If COVID give intense management of diabetes, remain in touch with healthcare workers, and when possible, at the first opportunity, get a vaccine done. All guidelines today, I tell you, whether it's American College of Clinical Endocrinology, ADA, IDF, or Research Society for Study of Diabetes in India, everybody wants that. Today, unrelated to current patient who visits us having had COVID or not, he should be as optimally treated as possible, so that even if he contracts an infection, the possibility of morbidity and mortality is minimum or at par with the non-diabetic population. Because all of us know the pandemic is not yet over. Thank you so much. It was a pleasure talking to all of you.
Dr. Zargar, for a very nice deliberation. You covered all the aspects of diabetes management, right from pre-COVID state to post-COVID state. And you covered everything. Patient already diabetic, having treatment, non-diabetic, developing diabetes, and how your rationale, your approach has been wonderful. And I don't think there should be any doubt in the mind of any audience about this presentation, how to manage COVID in diabetes during COVID pandemic. I have 1 or 2 questions which I would like you to explain to the audiences, just for the knowledge of everybody. Firstly, if somebody is not a diabetic, is it possible to acquire diabetes just with a course of 5 to 7 days of steroid? Second thing is, if the patient has been diagnosed to have diabetes, maybe first time detected during a COVID infection. Now, how long you follow the case? after the infection is over, whether the diabetes has actually developed or it was a transient hyperglycemia because of infection. So these are the two things which I would like you to clear.
This is a very brilliant question, because already many patients have started coming to us with these complaints. First thing about steroids, I must tell you, when we are talking about diabetes, all of us know that half the population in any community, even in the Western world, remain undiagnosed. In the Western world, the diagnosis of undiagnosed diabetes may be slightly lesser. But in our population, almost, if you do a community survey, if you find out there are 100 guys, out of 10 know that they have diabetes, there will be another 10 who will have diabetes but would not know that. Now, when such a person develops COVID and you give him steroids, probably first time we realize that he has diabetes, but he might have had diabetes even earlier. Second, there are lots of people who have pre-diabetes. When you give steroids, their pre-diabetes gets converted into diabetes. Thirdly, I told you as two papers published from India, Dr. Mishra published one of them, where we have seen that on the one hand, caloric intake has gone up and caloric consumption has gone down. Many of these pre-diabetics would otherwise also convert into diabetes. So in this class of people, if they revert back to their normal lifestyle, if they take care of their calories, if they again start working, they may again go into a pre-diabetic state, may not need a huge treatment. But there's a small group of people where, beta cells have been affected, and beta cell recovery can be very unpredictable. This is an infective process causing, in type 1 diabetes, you have an autoimmune islets. Here you have an infective islet. And the recovery from that islets can be unpredictable, and many of those beta cells may be replaced by fibrosis. So in them, diabetes will continue to be there. There was a beautiful paper published, work sponsored by NIH, where it was shown that this virus in some patients converts a beta cell into alpha cell. It's amazing what this virus can do. And instead of producing insulin, this cell starts producing glucagon. So the last word on this virus has not yet been said. Every day newer things are known. So best thing is, all patients with new diabetes, once they get, firstly, if they are not in remission, we need to treat them. If they get in remission, they minimum need to be on follow for a year or so. We know it does not come back. I hope that answers the question.
Yes,
Thank you
definitely.
very much.
Dr. Anand Minavat, would you like to ask any question?
Thank you very much. In fact, this information which you have given us is the one which everybody required. In fact, there were a lot of questions regarding this. We have summed up this question by Dr. Devda, who has been able to convey to you that these are the questions which we have received right from the time we have announced this. The people needed all these questions to be answered. Thank you very much, sir. You have been very kind to provide us a time when you have some trying situation in the family. I'm really grateful to you. Thank you very much, sir. Thank you, sir.
God bless you. Thank you so much. And pleasure is mine.